Hello, everyone. Welcome to the Speakers Dialogue of Inter-Face, organized by the Drama Collaboratory. Let me first introduce our first speaker, Amy Chen. She is a light artist, theater practitioner, and artistic director of Drama Collaboratory. The second one is Jason Chan. He is an associate professor in the Department of Otolaryngology, head and neck surgery at the Chinese University of Hong Kong. And our last speaker is Catherine Smith. She is an interdisciplinary visual artist and curator. Let us start our conversation. May I invite Amy to be our first, try to kicking start of the dialogue.
Good. So I think, well, about this speaker conversation, well, of course, for the project Inter-Face, so it's as mentioned in the name, so it's everything about face. So I think one or more or less, so we, well, of course, face is a very important part of our body that affects us in every aspect, socially, psychologically, physically, but I think what's interesting or important for this speaker conversation is that we have the, well, even including Enoch, our moderator. So we, all four of us are actually dealing with the face in a different way. So I think first of all, for Professor Jason Chan, so he's a ENT surgeon and also head and neck tumor surgeon. So definitely, so everything about head and neck is related to the face and also affecting the patient's face. So that's one very important thing. And of course, for Catherine, other than being an interdisciplinary artist and curator, she's also an expert in forensic face. So, and particularly forensic facial depiction. So I think that tells everything from the title. And for myself, maybe a bit more remote, but I think it's interesting because myself, other than being a light artist, so of course, light itself is a very, I think light for me is a very paradoxical media. So on itself, we cannot see light itself, but we definitely being affected and influenced by light, the media. So how we see our face. So right now we're in front of these 4 zoom cameras. So how lights are affecting our view on this zoom camera. So that's one thing. So I think that really tells how light is related to face in a very subtle, but yet a very significant way. And on the other hand, I'm also a practicing pathologist specialized in head and neck pathology. So I think that really makes it very special. Again, it's also as a pathology. So I think it's a medical specialty that is not always familiar to most of the audience. So, but well, imagine some doctors making a diagnosis through a microscope by looking at the tumor cells. So I think it tells. So we're always hiding in the background, but at the same time, because my specialist as a head and neck tumor pathologist, so that makes it always related to the work of Professor Jason Chan and also relates to the patient who has this head and neck tumor, the tumor in the face region or in the head and neck region, so much. And so I think it's also like my light practice. So although it's subtle, but it's significantly affecting everyone's face in certain sense. So I think that would how I start my personal correlation with face in this sense.
Thank you, Amy. Actually, she helped me to answer one of the simple questions I decided to ask everyone. The question itself is, what is space to you? And Amy already gave us a very good introduction and tried to help me to wrap up about the questions. And may I ask these questions to Catherine as well? Do you have any additional information you would like to share with us?
I think Amy's mentioned some really, really important points. I was thinking about this, it's a very big question and how to answer it simply. So I thought of maybe to say that for me, in my forensic work, I think the face is a technology of identification. But I think socially and culturally, we need to think also about the face as a technology of identity. And identity and identification sometimes we think of them as being the same thing, but actually they're not the same thing. So I think it's important to think through these two ideas. How do we think of them together, how they relate to each other, but also recognize how they are distinct from each other as concepts. For me, a face is a space. I think about the face as a space. You know, they're different concepts from around the world and through history, where the face is conceived almost like a landscape. It's got parts that project and parts that, so that's from a sort of a sculptural perspective, but also from a sense of how you think about the space as a three-dimensional object. You know, so often we encounter faces as two-dimensional images. You know, our passport photographs has us create this conformed appearance, which is not really how we experience faces at all. And this affects how we are able to recognize some people in certain situations and not recognize the same people in other situations. For me, faces are also a space where we project a lot of ideas about ourselves and about other people. So we project our sense of dignity, but also our sense of bias onto the face and the facial image. But like Amy, I also think about faces as a very big paradox. It's a primary object in terms of how we conceptualize and express and perform our own identity and sense of ourselves. You know, we think about everything from the history of selfies to Western portraiture, but they're also really unreliable when it comes to proving identity. So we think of them as having this great authority, like this is somehow the proof of me or you or whatever, but actually they're not. A facial image is not very good evidence. We don't think of them as evidence. So, you know, I might have an identical twin. You don't know that. Yeah. So I think there's some concepts about faciality, which we can get into maybe later a bit. But for me, I think in the current moment where we are so conscious of the face and how the face is being used or deployed in identification technology, I think there are lots of things to celebrate about how smart that technology can be, but there's also a lot of things to be really cautious about, and how that technology can be used maybe for not so good reasons. And I think for me, what the face now represents in terms of my own work is this interplay, the interface between the machinic and the technological, and personhood and the human. And so it's somewhere in between that I think I try to navigate.
Yeah. Well, thank you for that. Actually, I will follow up your questions in the second part. I'm curious about the idea of in-betweenness is very important.
Yeah.
So may I ask the same question to Jason? Would you like to share from your professional point of view what is space to you?
Yeah, I guess I have a bit of a different perspective in terms of what the face means to me as I approach as a patient-doctor relationship is what I'm working with a lot of the time in terms of dealing with a patient's face. And why is that the case? By the time somebody comes to see me, most of the time they have a growth in the head and neck region. This can be on the face, it could be inside the head, deeper down. And to me, when thinking of working with these patients, I have to conceptualize one, if it's not on the face, where this problem is inside their head, behind the face, and how do I help this patient? Obviously, they come to me for possibly surgery to remove any growths that they may have, and how will what I plan to do affect these patients? And I conceptualize it as a more practical person. And as I view the face and think how I'm going to help this patient, I view it anatomically in terms of layers in a way, as breaking it down. So for example, skin is obviously the most superficial layer you see, and we all see, but deeper down behind that, then you have the fat, the multiple facial muscles, the facial bones, the skeleton, and the three-dimensional makeup of the skeleton, and how this that comes to play to affect a patient's visual appearance. I mean, as Catherine and Amy both mentioned, it's also socially very important for these patients, and they themselves have their own identity of what this face means to them. And beyond just the appearance, it's also how I affect their functions of part of their face. So smiling, eating, drinking, speaking, which is all part of the face, and how I will affect this patient from that regards, and how I have this discussion with them of minimizing any trauma or disruption that I may have to some of these functions that we actually regretted. These are highly complex functions that we perform over our face. I mean, even smiling involves multiple muscles, multiple nerve fibers. Speaking is phenomenal in terms of what it involves. And so how we have discussion with them of what will happen during and after surgery, and how I can minimize any damage that I may cause to these patients. So I think my perspective is a little bit more of a practical relationship that I have with the patients, and how I build that dialogue rapport with them as I manage these patients to have the best possible treatment-related outcome for these patients that they can are happy with, while I'm also treating their problem, the disease.
Yeah, well, thank you. But may I, on top of this, I would like to have a follow-up questions, because this is a drama collaboratory project, right? So I think some people may really concerned about the details, the change of the facial for the muscle set, for example, the facial expressions, or also even the body gesture that may be influenced after a surgery. And how can you try to explain the details or the expectation to your patient that may affect that after or before the surgery? And is it something difficult for you, or can you share some more experience from your point of view?
Yeah, it's a very, very good question, Enoch. That's a very tough thing to explain to patients. It's difficult to show patients. I think prior patients before and after photos sometimes can help give an idea to the patients, but every patient is different. So it doesn't give them a full idea of what may happen. So for example, let's say in Hong Kong, one of the most well-known surgeries would be related to nasopharyngeal carcinoma, which is common in our locality. And if they have the disease, we swing their face open to see the back of the cavity where this tumor is. And you have a scar over your face. Usually the scar heals very nicely, heals very, very well, but some people may have some kind of, we call it ectropion. Their eyelid may kind of show a little bit more, so you see a little bit more of the white of their eyes. They may have some notching over the scars. And for example, if we have to remove the cheekbone, we also kind of open up the face here. In doing so, we damage some of the facial muscles. And what happens is the mid part, this part of the face actually can become frozen. And it doesn't move afterwards. But how do you convey this to the patient so that they will have a better understanding after surgery, and I think not be as shocked, because I think it also, if you can educate the patients earlier on, right at the beginning, the get-go, and they have buy-in and they fully understand to what's going to happen, it actually probably will enhance their recovery, both from a mental, psychological, and a physical standpoint. This will help phenomenally for patients, and it's something less for them to deal with the trauma of surgery. Right now, I don't think we have, to your question, we don't have a good way of showing the patient. I can show them in my consultation some of the CT scans, so the imaging that we do for these patients to show them where the growth of the tumor may be. But these scans or these images are all in 2D most of the time. It's not always in a 3D image that I can manipulate to show them, oh, this is here and this is how we're going to get to this area. It's intuitive to me because I've been doing this for 20 years, but it's not for a patient seeing me for the first time. They're going to have no clue. And I try my best to show them where it is and what may be around there, but I don't think they can fully appreciate what it is. And we do try our best to kind of explain to them how this will all transpire and look, but this is all by words and by descriptions. We're not very good at showing photos, and obviously there's some concern with privacy of showing other patients' photos. But if there's some way that I could, I guess, take the face apart, put it back again with some sort of imaging or some sort of patient specific, so dedicated that patient in a way based on the images, their scans, I think it could help the patient understand what they will be going through and help them a lot in working with the doctors together to help themselves as well. I think that is a very challenging area that we haven't quite got there yet.
Yeah, okay.
I think technologies such as VR, augmented reality, that we are seeing more and more of, and it's actually become more accessible to the public, will be hopefully useful in creating these images and help with education for both patients, physicians and training as well.
Yeah. So here start to discuss about the digital medical imaging as well. For example, when you talk about the CT image, and I would like to share with you one of my experience I heard by the other doctors, and sometimes they try to explain or elaborate the concept of a good or bad image. They sometimes they call the image looks good, and they try to explain it that way. And what is good and what is bad, or even look beautiful or ugly, this kind of conversation may happen in the way of trying to analyze about the digital imaging, the medical imaging. And do you have this kind of, I can't say bias, but this kind of terminology, ideology is quite interesting behind. And I would like to invite you and Amy, for example, to start with this kind of understanding and can share with us the common product. What is the ugly image and what is a beautiful image of a CT scan, for example?
I could try and start, I guess, trying to elaborate on what you mean by a beautiful CT scan. So I'd say, for example, I think one thing would be, let's say I have to do a surgery, I have to remove somebody's jawbone, their mandible, and I have to reconstruct that. I have to make it back to what it was before. And how would I say it looks good for the patient to be? I guess one thing would be if their facial contour at least looks symmetrical. Mm-hmm. And one of the things that we look for in the jawbone as well would be their occlusion, their bite. So if the teeth match up again. Mm-hmm. So if their teeth match up and they're able to chew and bite, to me, that is a win. That is a good outcome. But the patient may still not be happy because it's not just about the bone I've replaced, making the teeth coming back together. It's also about the skin, the fat, the soft tissue, the other materials I've removed that I have not replaced, so that their face doesn't quite look the same. And it doesn't have the same, I guess, texture, feel to it. And to the patient, if they're not expecting this may not be a good outcome. They may not see this as being acceptable to them, whereas to me as a physician, I'd be actually quite happy. So there may be a mismatch in expectation. It's hard to convey, I think. To me, if something in that context, if I can make their teeth come together good, well, that's already a pretty good outcome for me in a way. And at least having symmetrical shape to their jawbone. So that would be something that I would find acceptable and good. But yeah, I think hopefully that answers what you're getting at, you know.
Yeah, I'm trying to ask, but how about from a pathologist point of view, Amy? Is it also the terms you always use to describe or analyze an image like that?
Yeah, I think so, because I think actually, these terms or terminology always, well, personally, or a lot of us use it, definitely. We always describe, well, because I think back to what I'm doing, I'm a histopathology. So we're not like, so I'm not like Jason, who looks at definitely a grossly appreciable face. But instead, we look at individual cells or tissues. So it's not definitely not something really readily comprehensible or obvious to most of us, but only through the microscopy, under the microscope. But definitely, we're dealing a lot with the tumor diagnosis of tumor. So that's part of the, I would say, a very integral part of the head and neck tumor management, because, well, I think the diagnosis definitely affect what Jason will perform on the patient. So that's one thing. But another thing about the tumor diagnosis, we have to deal with what is benign or what is malignant. That means that you have to remove them totally or radically, or you can remove them more locally or more conservatively. And when we try to make this diagnosis of tumor cells being benign or malignant tumor, we always use the term, it's so inherited. We always describe the cells as, wow, this tumor cells are so ugly, so they must be malignant. Or, okay, the nuclei looks pretty good, so they probably are benign. So I think it's so inherited in our language or in our training. So I personally also use it. But at the same time, I myself is being troubled by this terminology or ideology behind this good or bad. Because why? Well, definitely, we know that the malignant tumor has a very poor or very adverse effect on the patient. So that's why the patients need to go through all this swing of the face, etc., like the case of the nasopharyngeal carcinoma, which is in the middle of our face. So it's really hard to assess. So we need to swing it. But at the same time, why we always need to associate the beauty with the more benign biological behavior versus the ugliness of the tumor cells as something more malignant. So I think that's an interesting, well, I still don't have a clue. And even for me being so critical of myself, I still can't get away from this terminology or ideology. So I think this is really something interesting, or as a something more, as a visual metaphor that we should look at more deeply, or even as a research, I don't know. But another thing that I want to, I find this very interesting for me as the work between me and Jason, because we work so closely. But at the same time, I find this when I listen to, well, we met each other in clinical meetings, so we know each other well. But at the same time, I still find his description about his works really amazing. And at the same time, I think it points to something for me about the face as a space, as Catherine mentioned, because I think, so for patient, so for surgeon, technically it's so difficult, I know that. So that's why Jason mentioned that even the teeth could match is actually a winning condition. But for most patients, or even for most of us, we have to admit that we accept the face as a holistic or as a totality. So as the entire space, or even I'm quoting Catherine in this sense, as a topology. So as a total space or landscape in the face. So I think that makes it a very interesting area. So versus our nowadays, our especially again from the point of view as a pathology, we try to make diagnosis. We now have a lot of advances using a lot of testing the genetic mutation. So whenever, say, a tumor has certain mutations, so we know that this tumor is this or that. But at the same time, I think face or head and neck tumor always tells us the other way around, because I think things are not that straightforward. Just one spot or one point, one positive finding can really tell everything. We have to look at, like a face, we need to look at it as a total space or as a totality. So I think that's my comment. So hi.
Hi.
Oh, great.
I just wanted to add to that to say that I think from my perspective of understanding it in a sort of a reverse way to Jason, is that the face it's an incredibly complex object. I mean, it seems weird to talk about the face or the head and neck area as an object, but it's incredibly complicated. There's a lot going on here. It's like our main sensory organs are all concentrated in this area. Our brain is housed in this thing that we talk about, our head and neck. You know, there's a lot of neurological concentration of neurological structures. It's just, and there's one major bone that moves, which is the mandible that Jason has spoken about. So thinking about it as a kind of as a feat of engineering is quite interesting, and that it has this internal world that we can't see, but we are always focused on its external appearance. It's fascinating, which is why we're talking about it so much, I guess, in this project.
I would like to ask further for Catherine about the holistic idea. For example, if from your background, you are a visual artist, you have a visual artist training. And for example, when you try to make a sculpture, and we try to focus on one part or starting from one part, or try to figure out the whole body or the whole section first in advance, and then try to make the details and refine it afterwards. And is it something very similar to your professional nowadays, talk about your facial reconstructions or even forensic in the concept of forensic?
Yeah, I mean, that's a really interesting question. One of the assumptions people make about artists who, like, say if you move into the forensic space from being a trained artist, which is the way that many people enter into the specialization, other people go the other way. Other people work within policing agencies, and they're like the one who can maybe draw a little cartoon, and their supervisor thinks they can draw, and then they get trained into the more visual aspects of that work. So it could happen in both ways. For me, as an artist, obviously I'm traditionally trained, but my own practice, I was never really ever interested in trying to represent the human form or the human body in a literal way. I was always working more kind of conceptually, but in principle, the kind of philosophical, I don't know, methodology, I guess, of what you're talking about is, for the face, approaching the face, it's like any composition, right? If you are planning a drawing or a painting and you obsess about the one area in the corner and you forget about everything else that's going on the page, it's going to look imbalanced in some way. So it's kind of like you've got to move between considering the whole and then considering the relative focus or the detail of certain areas. And if you get certain areas of your composition right, your focus will be pulled, and it will allow you to kind of pay attention to certain details, but also consider the whole. And for me, when I'm working on a facial reconstruction, it's very much like that, where we do pay extremely close attention to each individual feature, because we are concerned with the relationship of the soft tissue and the hard tissue of the face, and trying to work backwards from the skull to produce a plausible face that is plausible enough for someone who knew that person to identify them if they are unidentified. So this is in the case of post-mortem, unknown people who have died without they've become separated from their social identity, their legal identity in death. So we use the facial image to try and bring those two things back together. However, if you're also working, and this is now thinking about, say you are an eyewitness to a crime, and the police want your assistance to identify the potential criminal, and maybe they ask you to describe this person, and then they'll create a facial image of this person of interest. There you're working more with memory and recall. So there's more of a kind of cognitive psychology element to it. But this issue of whether we think about the holistic face, which in psychology they refer to as a gestalt, or whether we look at the individual features, that becomes really important in that field specifically, because they realized some time ago that the traditional technologies they had developed to help police officers create these composite or suspect faces were all feature-based. So they would say, describe the person's nose, describe their mouth, describe their eyes, just breaking it down into features. But that's not how we see faces. It's not necessarily how we record faces in our minds. So to ask an eyewitness to then break it down feature by feature is kind of counterintuitive to how our minds actually work when we think about faces. So the realization that we think about faces, we encode faces holistically. We're almost subconsciously picking out some feature-based information, but we're thinking of these things, of the face as a whole. They've now developing different kinds of facial composite technology that works on what they refer to as an evolutionary algorithm, and it produces this more holistic face than this feature-based. That's why the earlier kind of identikit faces that you would see, which have become a bit of a cliche now, they look like Mr. Potato Head. You have this oval shape and then they put the eyes, nose, mouth, and it doesn't kind of fit together properly. It's because you're not conceiving of the face as this holistic form. So it's fascinating because you can answer this question from a number of different perspectives, and you kind of always arrive at a similar result. Like the face is a holistic object, and it's not only how we should approach it, but also how we are actually perceiving it cognitively.
Yeah, that is very interesting, because sometimes when I try to watch some criminal or drama, for example, they usually try to describe, oh, can you identify a person, and try to remember their characteristic, a specific facial characteristic, something like that. They would never try to explain, can you give me a holistic image or your memory? It is very strange to our perceptions, I think. And
yes, and if you think about even faces of people that you know very, very well, like one of the main ways, one of the most powerful ways this effect was, I appreciated this effect, and it was in a training session where it was like more about, here, just learn this facial software, like see how you feel about this composite software that the police would use. And they said, oh, just make the face of someone you know well. So I thought, okay, well, I'll think about my partner.
Yeah, that's right.
It was terrible. I couldn't do it. And this is someone I've lived with for nearly 20 years. Yeah. So how then are you expecting an eyewitness who probably experienced this person's face, probably partially because the light was bad or it was dark or they had a mask or any other way which their face might have been obscured, and it's a stressful situation, they might be traumatized, and you're saying now you must remember the exact shape of their eyes, nose and mouth. This is going to be impossible. Yeah. So this new software, what's interesting is it allows you to kind of, it's very complicated, I won't go into the details now, but once you've arrived at a face that's more or less right according to their memory, you can then also, it allows you to adjust the facial appearance more towards the facial expression. So it has these qualitative sliders that allows you to increase the anger in the face, or like the health of the face if the person didn't look very well or malnourished or whatever. So you are allowed to add these holistic qualitative aspects to this face, which actually starts to convey more useful information than specifically the feature-based information. Unless, of course, the person has an extremely characteristic nose, and then in which case you want to put that's useful information.
Yeah. So
a question from a light artist. So is there any consideration of lighting conditions for that software to help the recognition? Is there any something as a choice in that software?
It's a good question. I haven't seen the most recent versions of the software, but it's certainly something that you are encouraged to ask of your eyewitness, so that you can make further adjustments to that image, maybe in Photoshop, so outside of the immediate environment of that software, because it will have its limitations, right? So if it's nighttime, if you're doing your interview properly, using the advice is always to use a cognitive interviewing process. So there's a little bit of context reinstatement. There's a technique that is better than simply saying, describe their face, you know, because there's a certain amount of context reinstatements. As long as you are fairly convinced that that's not going to be overly traumatizing, that can be really helpful with the retrieval of that facial memory. And then finally, when you're presenting that image, for me, it always goes to, you know, the presentation of the image. Then if the light was coming at a very specific angle, then you can include that. That sometimes can be very helpful. The general convention, I guess, is to try and, certainly with the facial reconstructions that we produce for deceased people, but it will also be true of historical reconstructions we might do from an archaeological context, which is more for museological interest, you know, heritage interest. We try and replicate a kind of daylight lighting situation. So the light's above your head and it's sort of at a slight angle. The slight angle just gives you more of an opportunity to describe certain facial. You get more of a three-dimensional sense of the face, even though you're presenting it in 2 dimensions. Assuming you're otherwise, you know, if you're doing a sculpture, then you have the opportunity of looking at it from all angles. But normally, in this case, it's an image, and you try and work with as much as you can put in that 2D image to refer to the 3 dimensions.
So is this also very challenging for you? For example, if someone asks you to help them to identify, is it the same person? So is there any technique trying to identify, is it identical the same person, or using what kind of criteria as the background to support your findings?
So there's a lot of software out there that claim to be able to sort faces out and say that this is facial recognition technology. But from a human examiner point of view, there's a group called the Facial Identification Scientific Working Group. They're an international body of people that have put together a series of guidelines for the application of facial identification analysis for forensic contexts. So although the face is a facial image is never considered evidence, it's always considered a form of investigative intelligence. So it can provide the leads towards scientific proof, but it isn't proof in itself. Within law enforcement, the process of facial identification, they do unfortunately use the term identification, which is a major point of confusion, that it is somehow proof of identification, which it's not. But in the practice, which is now it's considered a discipline, facial identification, facial analysis and comparison is the major kind of activity you would be involved in. So you might have a target face, and then you might have CCTV image, and is this the same person? So there's a morphological, the technique. If I was asked to do this, I would apply the facial identification scientific working group's morphological analysis schema, and there's certain facial features which are very useful to an initial kind of like a filtering process. So if, for example, I can clearly see the ears of 2 people, and those ears look very different, even if their faces look almost identical, there's a very small chance that they're the same person. So the ear shape would be an immediate exclusion. And all you can really do with facial comparison is state, according to degrees of confidence, whether you think that it is likely that this is the same person. But you can't ever say for sure, because you're also limited with the tools that you have available to you. You're working with images. Those images are produced under certain conditions. There might be artifacts that affect how the face looks in those images, you know, whether it's a low resolution photograph versus a high resolution photograph. There's so many factors. And if you are too confident in your ability, it probably won't work out very well for you in terms of getting future work. So it's also just ethically better to err on the side of exclusion. Because if you are working in a legal framework and you say confidently that this is the same person and they're not the same person and they're being accused of a crime, that could have very bad consequences for that person. So ethically, rather ensure someone's liberty than a false conviction, I would say.
Yeah, sorry.
Sorry, Amy.
Okay.
Please.
So yeah, just curious, because after Catherine sharing this different perspective of face with this all scientific investigation, of course, it's for more, I would say, more legal purpose that we need to make it more stringent. But on the other hand, that makes me curious that how could that thinking or evaluation could be applied to, say, back to the clinical practice of head and neck tumor. I don't know, because it seems that from Jason sharing that the head and neck tumor management patient-wise, so it seems that it's so individual. But on the other hand, is there any research or any ongoing things that helps really to make it in to assess the patient's outcome or everything in a more scientific or but at the same time individual way?
I think for us in terms of reconstruction, there's more recreating what we've removed. There's something like virtual surgical planning. So using CT scan imaging of the face beforehand and the tissue we may be taking to repair. For example, the fibula bone, if we're reconstructing the mandible bone or even the mid-face, the cheek area, then we can plan beforehand to the shape of to guide the bones you want to cut to create the shape that we want, particularly just the bone. It doesn't give you necessarily the soft tissue component, the component that overlies the bone. That is very, very, very challenging to do. I think it's right now we're just not there to do that. We can reconstruct the bony parts. I think we're getting very good at doing that. It still takes, if you use a commercial company in Hong Kong, it takes 2 to 3 weeks. So, some people I know in a dental school, we do it in-house, but they use a lot of manpower and do it within a week. Obviously, you don't want to take too long because if it's a malignant tumor. But these the work with the bone is actually, I think, pretty good now with technology. One thing we very not good at it is, as I mentioned, the soft tissue. So the skin, the fat, the muscle overlying it. I mean, recreating and re-innovating muscle to move is already very, very challenging, I think, in reconstructing the face. But even just to have something that covers it to look like what it is before is difficult because this will all warp. Once you've done the surgery, they're swollen. They're very, very swollen in the face. And that's a function of the damage you've done to the surrounding tissue, the tissue you put up there, it all swells. The swelling will settle down, but then for example, the fat, your body will reabsorb. So how much goes away, you can predict it's about 50%, but you don't know for sure. And then on top of that, you add in radiotherapy that these patients will get, which makes it lose even more. So that is very, very challenging to do, to measure, recreate, I think. I mean, talking about morphological measurements, if we go to facial plastic surgery, they have a lot of measurements of the face that they use. So for example, they typically divide from top to bottom the face into thirds. So above your eyebrows is 1/3, your mid face is 1/3, your low part is 1/3, and you can cut your face into fifths longitudinally. So, for example, your eye is 1/5, your nose is 1/5, and so we have a lot of measurements we can use to create from a normal face to a better face, or what we call. There's a lot of work, I guess, in the Caucasian work and maybe careers, or what was the ideal face, or what are the ideal proportions to recreate. With facial plastic or cosmetic surgery, that is present. But for what I do with somebody who's a tumor and I take something away and to make them go back to what they were before, right now we don't have that available just yet. I think that's very, very challenging to do it well. Yeah.
It seems that yes, sir.
Sorry, Amy, please.
I think Catherine also has a.
Oh no, I was just going to say that it sounds like, you know, we have the same thing in forensic reconstruction. So there's a lot of facial geometries that we could apply. And you know, we're very good at understanding the soft tissue, hard tissue relationships of certain features to be able to recreate that feature from the bony information. However, some of those actually are quite anecdotal, because you realize when you go back in the literature, they actually just come from painting. You know, they come from Renaissance portraiture, and you're like, well, that's not actual data. That's just someone's opinion of like what looked nice. So like, how valid is this now? But it sounds to me like, in terms of this kind of surgery that you practice, Jason, I'm hearing something very similar with how we need to approach cases from a forensic perspective, which is very much on an individual case-by-case basis. So we are trying to reconstruct an extremely individualistic, characteristic face that belong to that person, that is how that person would be recognized, rather than striving towards some kind of facial type, ideal facial type.
Yeah, I agree.
But is that possible that some patient, for example, if I need to do a tumor removal, but afterward I would like to have a holistic surgery, that I can finally finish my plastic surgery as well altogether and try to make myself look better? Is it possible, or too ideal to working with that?
Yeah, I mean, nowadays we try to do everything at the same setting. So we would remove, for example, I guess maybe a good example would be, for example, a parotid tumor. Let's say the product gland, your salivary gland here, which secretes saliva, helps you moisten your food, chew your food. And some of these tumors, they grow, they can involve the skin here, but they also invade into the facial nerve, the nerve that controls, I guess, the muscle motion, your eye closing, your smile, your movement of your forehead. So if we cut that, we damage all these movements. So when we try to reconstruct this and help the patient, what we can do, besides, for example, to remove skin, we find something to cover the skin. We can also connect the nerve back in different ways. We can either connect it back with a nerve in between, or sometimes if we can't do that, we can do certain surgical procedures to give them back a smile, be it preparing a nerve for later down the line and putting muscle back in to create a smile, or actually it's static, so something that is not dynamic, but something that gives them a smile. It looks a little bit odd to begin with, but functionally, actually, it's useful because one, they can have a social smile when they smile, and also they don't drool, which is one thing. We can also do certain things with the eye to help with eye closure, for example, putting some weights inside the eyelids so they can close their eyes. So nowadays, we do most of these things in the same setting so that the patient has one surgery. It may be a very long surgery, but they remove the tumor and then we reconstruct to give them the best possible functional and aesthetic outcome that they can possibly have at the same go. So we do try and do that. Yeah.
Okay, perhaps we start a lot of very practical and professional discussion here, and let me try to challenge everyone. I want to put art back to the conversation. Okay, is that, for example, as I remember, a term called forensic art, and even a kind of pathological art? May I ask, what exactly that means to you? For example, let me start from Amy, for example, what is pathology art or the art of pathology for you? And would you like to explain a little bit for us?
I think that's very interesting because it's not just the art of pathology, but we always have a term like art of medicine or art of surgery or even art of oncology, which is the specialty about dealing with the tumor. So when you go to the search engine for medical journals, you type art of medicine, so you find tons of it. So it's really interesting. But I think that's a very interesting notion that just what Jason has mentioned is definitely an art. But I think art can be in a different sense. So of course, on one hand, we can, well, it's interesting, very interesting notion that we have this science of medicine and art of medicine. So it seems that we're trying to tackle the medicine in two different perspectives. I find this very interesting. But on the other hand, I think as a medical or whatever specialty practice, it's not just about science, or the science is not just science and art, but it's definitely something more complex, I would say. So so back to this art of medicine or art of pathology. Of course, it's a very complicated issue, but let me put it this way. So of course, on one hand, we can put it in a very metaphorical way. So we mention all those difficult or very artistry or craftsmanship of the medical practice as an art. But personally, of course, my background as a artist or a theater practitioner is not satisfied with such a definition of arts. So I think another sense would be about arts and beauty. So we talk about all these tumor cells being ugly or beautiful. So it's another sense, so which is interesting. I just raised this up. I still don't have a clue yet. But on the other hand, I think, well, for me, and why I find this occasion very, very precious or very exciting is because all four of us has a really different backgrounds in arts and particularly medical science. So I think it seems that nowadays with our highly labor divisive institutionalized society, it seems that arts and science or arts and medicine seems to be the two ends of this spectrum. But I think personally, for me, it's definitely that case for sure. So it's not that simple, art here and science here. And of course, it's definitely not just, well, in some sense, when you talk about this art of pathology, I do see some exhibition by pathologists trying to, artistically, well, manipulating pathology image. Definitely, there's certain beauties in those cells and images, but is that the only aspect of art? Can art inform us all or more, or can art and science have a more different perspective? So I personally, well, I think that's just a very one very superficial layer of this, about this common notion of arts of medicine, of art of pathology. But I think there's much more deeper and more different variety or a whole lot of diverse spectrum that we need to explore. Maybe not just arts in the surface of representation of science or medicine, and while on the other hand, science or medicine or technology is not just in service of making arts and other different media. So I think that's my answer to this. I still have a lot to say, but I just stop here.
You're welcome to continue, actually.
Yeah,
but I think, yes, but I think, yes, would it be the same challenge and notions in terms of forensic art? Is it too practical when we have a understanding or misunderstanding of the term forensic in a very practical way?
Yes, I think absolutely we have a misunderstanding of the term forensic on the one hand, but I think we also have a misunderstanding of the term art on the other hand. And when you put them together, it's double trouble.
Yeah.
So if we just approach the forensic first, I mean, forensic really simply means for the law. And I'm really interested in the kind of very original, where the word forensic comes from, its kind of Latin roots, speaks more to the public forum. So, which is where you would like the courtroom is a public forum, and this is where you lay out a case in public, in the public interest. It gets debated, and a decision is made, in the interests of justice and the social good. So, I'm really interested in this kind of public good aspect of the forensic. It's become through time. And there's a theorist called Eyal Weizmann who uses this fantastic phrase. He talks about linguistic telescoping. So like what language does is it kind of shrinks things or expands things. And the forensic in his mind, that kind of has telescoped down into something that means either we can use it in everyday speech to refer to something that's extremely detailed and particular, like you're looking very closely at something. It's like down the microscope. Or it refers to the kind of forensic, what we understand from entertainment media, like the kind of criminal procedural drama. You know, it might take place in a forensic context with the lab, or, you know, so I get that question a lot as a forensic artist. Are you like Angela from Bones? And I say, no, because we don't have a hologram machine that magically produces the reconstruction. It would be lovely, you know, I aspire to that, but that's not really how it works. So, and also what those shows, you know, and I have a lot of students. You know, I was also that student once, many, many years ago. I wanted to know how you could, I knew it was possible to be an artist in the world of policing and in the world of pathology, because I was really interested in forensic pathology specifically, but I had no idea how to get there. Like, what did I need to study? What's the career pathway? Like, my guidance counselor at school couldn't tell me. You know, and 20, 30 years later, I'm sitting here with the same problem. And obviously now, you know, I think CSI first broadcast in the 1990s, you know, so it's been in the public imaginary for 2 decades now, coming on to 2 decades, more than 2 decades. And increasingly, I have students now who find out that I can do this, and they also want to know how to do this. And, you know, what is forensic art? Well, you know, forensic art has probably been around as a phrase for about the same amount of time as CSI has been on TV, maybe slightly longer. The history is, I'm trying to piece together the history from different perspectives. Part of my PhD was trying to write this background, because there isn't a generally agreed history. Like, there isn't a generally agreed set of standards of practice, which is a major problem. But really, the art in forensic art really only talks to the deliverable, you know, the fact that you're delivering a visual image, you know, whether that is of a suspect or a facial reconstruction of some description in the attempt to identify someone, or sometimes you are also producing demonstrative evidence to present in court, you know, so whether it's a crime scene this part is not so well known, but a kind of crime scene reconstruction, a spatial reconstruction versus a facial reconstruction. I don't see why that shouldn't also be considered part of forensic art and illustration, because, you know, and likewise, there's another aspect of forensic art which is often excluded from what I do, which it shouldn't be. It's just less well known and less practiced, and that is and it's closer to medical illustration. So it's producing demonstrative evidence for court where someone may have been injured in a car accident. You know, and for the same reasons that Jason was speaking earlier around sensitive images, there's privacy issues around using patient photographs. There is ways of doing sort of injury depiction for court using an avatar figure and then reconstructing the injury on the body to prevent sensitive images from being shown in court. It's not necessary to do that. And it's particularly true if it's a case where someone's been murdered, for example, and their family may be attending the court case, or there's a jury made up of members of the public. You want to shield them from unnecessarily traumatizing images. So there are all these other sort of hidden areas to forensic art, which I think are really interesting, which we could promote a little bit more, because I think there's you start to see the connections then more closely between the kind of biomedical visualization, which you might apply to, you know, patient information, patients understanding surgical procedures or disease processes. You know, maybe your family member's been affected by a particularly like degenerative disease, and you want to understand how that's going to affect their body and functioning as the disease progresses. There's, you know, it's really interesting to visualize that. It can be a really helpful tool. And really, forensic art is when you take that kind of thinking and you apply it to the forensic context.
So actually, it's also involving a kind of imagination and even expectation. Can I understand in that way?
Yes, I think for me, from the kind of the broader understanding of what art is, right, is it involves different types of knowledge. and different types of knowledge which you gain as a practitioner. And this is one of the reasons why I always say that I think artists and surgeons or medical practitioners are very similar, actually, because we combine both visual and haptic knowledge. We construct our understanding of something through how we observe it and how it feels. And the feeling part of the knowledge is very difficult to communicate often, because it's a kind of embodied knowledge. We understand the difference in the texture of something. Like something doesn't feel right, like literally, if it feels a bit harder when it should be softer, and that kind of stuff. But that's very much what I refer to as a kind of tacit knowledge. And the challenge often is moving it from the tacit knowledge to the explicit knowledge. Like, can you explain this? Can you articulate this in words? Language often is very limited in doing this. Absolutely. And you need to experience it for yourself. Yeah. So the art, this is where I think the art or the of pathology, or the art of surgery, and the art of art making, is the art of combining this craft, technique, theoretical, empirical. It's like all of these different types of knowledges combined together, and you're doing something which you can explain to a point. But for the rest, you've developed this kind of database of experience where somehow you just know. And that's all you can really say is like, I intuitively, like, I just know. But of course, you don't just know. That knowledge has been built up over time in some way, but it's incredibly difficult to explain why you know that. So the art part is that kind of ineffable aspect of interpretation, where you can put all of this information together and somehow communicate something about it, but certainly not everything.
Yeah. So that's why it's also very challenging, for example, for Jason's, how to explain to the patient that what will be the outcomes after the surgery, and then how the details can be described by word actually is almost impossible. So is it, for example, I asked the question to Jason now, is that some patient or their family ask you how the details could be? For example, one term you mentioned before, the social smile, I think is very fascinating for me, because it is very subtle and you don't even notice, but you just know that there's exists. Well, it's just a social smile, but at the same time, if that not looks very, how to say, it's not looks that normal or natural, and that becomes something very strange and create problems. And is this a kind of challenge as well for you?
Yeah, I mean, if we talk about communicating with patients, you can imagine if you saw somebody on the street and their face was mask-like, or they don't smile, then you feel they're unwelcoming, and you don't want to talk to them. But in a lot of our patients, they may have something that's not under control. I mean, they don't have that smile, but unfortunately, it's because they've had some damage to the tissue from surgery or from the growth of tumor, that they can't smile. And I mean, this is almost like a feedback loop. If they feel that way, then they start getting depressed. They start feeling unhappy. Everything doesn't seem to be going the right way. So the quality of life is severely affected as well. And I think this can one thing that affects one thing of the face, but even, for example, eye closure, they can't close their eyes properly. We sometimes may have to remove tumors of the eye. They lose one eye, they have an eye. And I think also practice where we talk a lot about symmetry. And an asymmetric face is very, very odd looking, and very, very noticeable to the layperson. So if you're walking down the street and somebody, when they smile, one side goes up and the other side doesn't move, it's very, very obvious something is abnormal. And people seem to feel repugnant of that. They don't get attracted to it. They feel concerned something's not quite right. And I think it's a natural feeling. And that's something we also try to address, symmetry, because we know from facial plastics, even for example, scars, if you create something that's asymmetric, it looks very odd. Another good example would be a thyroid scar. So in the neck, even though we're taking only one side of a thyroid gland, which is on both sides, we make a scar that comes across both sides because it looks symmetric. It's not off to one side, and it's less obvious to the people that are looking at it. And the other things that really affect our patients are speech and swallowing as well, which are a function of the face. Using their tongue, articulating, creating sounds, moving your tongue, moving your cheeks. Those all involve facial muscles, facial movements, and affect patients' swallowing and speech. And I mean, we all want to talk to people. We all want to communicate. Eating together is a form of communication, a form of social interaction as well. And these patients may feel withdrawn because they can't eat or drink properly. So I think we do damage a lot of these patients. And if we're talking about face, to me, it's not just the external face, it's everything that encompasses deep down as well that can affect patients.
So I think it's very interesting to know about these details and observation and how to deal with patient expectation as well, because I think maybe that is also why one of the art and science program that Catherine mentioned before is asking the medical student to do live drawing. Would you like to explain a little bit about this idea? Because I find it very interesting to work with art and science together.
Yes, so this was locally here in Cape Town in South Africa, a colleague at a university here who runs a public health, he runs the public health department within the medical school. And he became concerned that students, medical students who are spending a lot of time in dissection, they're learning about anatomy through the dissection of cadaveric material. And he was concerned that he was wondering about the potential impact of their bedside manner on living patients once they had spent so long being conditioned, part of the professional conditioning of medical training. And I experienced this as well in my own anatomical training of separating, and it's very important for one's mental health, I think, while one is trying to acquire so much knowledge about human anatomy, is separating the individual person from what you're observing. You do need to kind of nurture and construct and foster this sense of a kind of critical objectivity. But where science often talks about objectivity as this sort of self-evident thing, I think we know actually that it's a construct and it's a learned behavior within the world of anatomy, certainly. And he was interested in how does this affect your potential future relationship with a living patient? So his idea was to then take the students who would spend their time doing anatomical dissection in a life drawing class. So they were then recreating what they were deconstructing in dissection, but faced now with a living, breathing model that they could also then look at. And it's something that I do when I teach drawing, is get students to think about the relationship between surface and structure. So how can you imagine that you've got X-ray eyes and start to visualize the structure beneath the surface of the skin? So very classical example of anatomical illustration from, the time of Vesalius is the écorché drawing where the body appears flayed and you see all the different layers of the anatomy. I get students to do that obviously in an imaginative way, because we're not dissecting our life models, God forbid, in the life drawing studio, but they work with a life model and they have a skeleton and they have different anatomical models to refer to, and they start looking at the way that the muscle and the bone starts to create the form of the body. And if you're teaching sculpture and you're thinking about drawing in relation to sculpture and how you observe a three-dimensional reality, you translate it. This comes again to this idea of translation, which I think we're all busy with in some form or another. You're translating it to 2 dimensions, but then you might need to remediate that, retranslate that to 3 dimensions again. It's very important to understand how shape works. And that shape is not just the external surface, the superficial but also it has a structure. There's something that is informing that shape, and getting them to understand that.
Yeah. So it is a very good example. Sorry,
I'm just going to ask Catherine. I know they were doing the sections in cadavers, is what you mentioned, but there's a big drive, I think, because there's not enough cadavers to do this all electronically. So some US medical schools are using augmented reality, so using Microsoft HoloLens to walk through the body and teach. We have in CU the anatomage table where you can kind of flip through go through those different layers, and they look even less lifelike. I mean, the cadavers, at least you can relate to. It's an actual human being, or was a human being. Lifelike tissue, you can touch it, you can feel it. Now we're moving towards these more computer-generated modalities, which I think we probably will see more. I guess it's always an argument which we should use more. But I mean, how does that affect the objectivity? I find whatever's generated computer just is not the same. It's completely different to me. And whatever's been done over the last decade or two, it just does not feel the same as a cadaver. It's just doesn't feel the touch, the look. And so I don't know how you feel about that.
You know, I'm very much one that welcomes technology into the world. I mean, I just, a pencil is a technology. We're just now super sophisticated with augmented reality and things like that. But, when it comes down to this question of the understanding the human body as a subject and an object, because I don't, I made an exhibition once called Between Subject and Object, because I think it's precisely that. I think we are both objects and subjects at the same time. And we there's just certain frameworks we can understand, ourselves and, in both of these things. It's like walking and chewing gum at the same time. You need to hold two kind of competing ideas in your head at the same time. That's when things really get interesting. But where the augmented reality comes in, as someone who's had the great fortune of training in anatomy with being exposed to a lot of cadaveric dissection and different techniques of embalming, I think even then you have a totally different relationship to the body. So, working with your standard formalin cadavers, which seem quite stiff and gray, and none of the colors are naturalistic anymore. And, it's quite easy to objectify that object, that thing in front of you, to your other more teal embalmed cadavers, which are like hyper flexible, like completely wrong in terms of how flexible they are, but the colors are much more natural. To this, I don't know what the third technique is precisely called, but I encountered it in Australia, and that was really the most naturalistic, and then, so having seen all of that, and those are all preserved bodies in some way or another, and then in the forensic pathology environment of the medico-legal mortuary, where there's no preservation at all, and there's often a considerable amount of trauma. You're seeing bodies in the worst states imaginable, like across the spectrum. And having had that experience, and then thinking about augmented reality, what I'm missing from that in terms of being able to connect with the body is everything that isn't visual. There's a sound component, there's a haptic component of how you know that something is non-normative because it doesn't feel like things should feel. It's like palpation. There's smell, obviously. And I think a lot of that stuff, particularly when you're training and you're kind of working out your kind of levels of empathy, and there's all of this sort of what they would refer to as the hidden curriculum. It's not the stuff you're being taught. It's all the other stuff that's actually informing your learning journey, but you don't ever really get to talk about it, although we should probably. There's that stuff, which is totally missing from the augmented reality. As much as I fully appreciate the ability to, like, on a vertopsy situation, or like move my hand in space and sort of turn a virtual page of the body and like flip the next layer, that's amazing. But to me, it's like, isn't that just a fancy version of those anatomical flip books that they used to, what flat books they referred to them. It's kind of just like that, just a fancier version of that. And for me, what is the most important thing is, how do things smell? How do I feel? It's the embodied knowledge part that the augmented reality, I think, is really trying to get at, but it's going to miss it, I think. I worry about that.
So as a theater artist practitioner, we appreciate that other senses other than visual and narrative. So I think that's all embodied, but it's hard to communicate through language, but at the same time, it's all embodied memory that really helps us to get a sense. So in the case of contemporary theater, that we do a lot of theater with all other senses, with the sound, even smell, or even perception under your foot. So I think that really points to something that, well, may not be, I don't want to put it like as an application or as an art, so it's so important to remind us. I don't want to really put it like that, but I think at the same time, at certain level, that definitely, I think that what arts could really inspire us in terms of this medical education and also in the practice of medicine.
I'll just add one more thing there, and that is from when we do our work, whether it's forensically or archaeologically, there's a big conversation finally being had around the world now around the ethics of working with human remains, and especially if you don't necessarily have consent for those remains. So you might have skeletal material collected into museums, and it's, you know, of archaeological interest. So is it appropriate to make a facial reconstruction of that person for, you know, whether they might be a known individual, they might be an anonymous, you know, someone from an archaeological context who has, we don't have their identity anymore. Is it appropriate to make a reconstruction of that person for heritage interest, you know, for museum visitor interest, etc.? That's another whole conversation. But one of the things that we learn from the biomedical space, bioethics space, is to what extent we can treat that material optimally. So we don't necessarily, I think forensics has also learned a lot from this. So you attempt at the very least to be non-destructive about how you work with that material. So now CT scanning, for example, enables us to reproduce a 3D model from a skull. We're not physically having to cast that in silicone or alginate and plaster anymore, which obviously, if it's a very fragile object, you would run the risk of damaging that object. So medical imaging has enabled us to be non-destructive. Whether or not we're being non-invasive, which is often a claim made about this material, about these technologies, I'm not sure that it's really like always fully true. But in any case, so there was an amazing exhibition of different ancient Egyptian mummies at the British Museum years ago, and they used beautiful CT-based imaging, you know, and using visualization techniques to kind of color things, do things in different layers, and you could effectively unwrap the mummy from its external beautiful painted cartonnage case down to the skeletal material, because this was obviously the whole problem with, especially with ancient Egyptian mummification, is that in order to explore the interior of those objects, you would have to destroy them, and you couldn't put them back together again. Medical imaging allows us to do that now, but yeah, there are some ethical questions there, and I think it's really something that that exercises my research, is thinking through this work, because I'm compelled to do it. I mean, of course, one can say no, and I have said no to certain requests, but it does guide one's practice in a way to ensure that one is treating that material with as much respect as you would a living patient. And I think that's really the point.
So perhaps we discussed a lot about the in-betweenness of the possible between science and art, and even the possible and even the ongoing practice between art and science. Okay, so thank you for all the conversation today. Personally I saw and learned a lot, of course, and I can imagine a lot of possibility. And this kind of conversation will be ongoing for years, I'm sure. And please invite and try to organize further. And it's very important. And I personally would like to conclude this session that it is something open-minded and surely not only stick to a rather narrow concept of STEM, which is very highlight and keep promoting in Hong Kong in recent years. The STEM without the aid is terrible. Okay, thank you very much and looking forward to the next sections. Okay.
Thank you very much.
Thank you very much.
Thank you, everyone. Bye.
Bye.
Bye.